بسم الله الرحمن الرحيم.
قالوا سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم.
بسم الله الرحمن الرحيم، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Regenerative or Reconstructive Osseous Surgery, presented by Professor Mona Yehia Abdelrazak. The ultimate goal of periodontal therapy is to regenerate the tissues that have been lost due to periodontal disease. The regenerative surgical techniques can be subdivided into non-graft associated new attachment, graft associated new attachment, biological mediator associated new attachment, or a combination of the previous approaches. Non-graft associated new attachment include the removal of the junctional and pocket epithelium, prevention of their migration into the healing area after therapy, the biomodification of the root surface, clot stabilization, wound protection and space creation, guided tissue regeneration, and laser-assisted new attachment. However, the role of laser in periodontal therapy remains controversial. Periodontal reconstruction can be attained without the use of bone grafts in meticulously treated three-wall defects or intra-bony defects, and in periodontal and endodontic abscess. New attachment is more likely to occur when the destructive process has occurred rapidly, such as after treatment of pockets complicated by acute periodontal abscess and after treatment of acute necrotizing ulcerative lesions. The methods that are used to remove the pocket and junctional epithelium are curettage. The result of removal of epithelium by means of curettage varies from complete removal to persistence as much as 50%. It is therefore not a reliable procedure. Ultrasonic methods and rotatory abrasive stones have also been used, but their effects cannot be controlled because of the clinician's lack of tactile sensation when using these methods. The chemical agents have also been used in conjunction with curettage. The most commonly used drugs have been sodium sulfide, phenol, camphor, antiformine, and sodium hypochlorite. However, the effects of these agents are not limited to the epithelium, and their depth of penetration cannot be controlled. They are only mentioned here for historical interest. The surgical techniques that are used to eliminate the pocket and junctional epithelium are gingivectomy, which is used to the crest of the alveolar bone to debride the defect, the excisional new attachment or INAP, the modified Wiedemann flap that eliminates the pocket epithelium with internal bevel incision, or the coronal displacement of the flap. This increases the distance between the epithelium and the healing area. This technique is particularly suitable for the treatment of lower molar furcations and has been used in conjunction with citric acid treatment. Prevention of the epithelium migration is done by elimination of junctional and pocket epithelium, which may not be sufficient because the epithelium from the excised margin may rapidly proliferate to become interposed between the healing connective tissue and the cementum. The most important method for the prevention of epithelial migration along the cemental wall of the pocket is the so-called guided tissue regeneration, or GTR. It delays the epithelial migration into the healing pocket. In the process of guided tissue regeneration, as we see, a device which is called a barrier membrane is used. The regeneration is the biologic process by which the architecture and function of the lost tissues is completely restored. regarding the periodontal regeneration is the restitution of the lost tooth supporting tissues, including new alveolar bone, new periodontal ligament, new cementum, and gingival structures. Guided tissue regeneration as a method of attaining new attachment. New attachment is the reunion of connective tissue with a root surface that has been deprived of its periodontal ligament. This reunion occurs by the formation of new cementum with inserting fibers. This definition is done by the American Academy of Periodontology in 1986. Procedures that may generate new attachments are flap debridement, bone grafting, and guided tissue regeneration. The periodontal membrane is considered the primary source of cells necessary for periodontal regeneration. The endosteum of bone is also considered a source of undifferentiated cells. This is a diagrammatic presentation of the periodontal pocket as we see in A, before treatment. After treatment in B, by scaling and root planing, the red arrows show the fast-moving epithelium, number 1, the slower connective tissue of the gingiva, number 2, then followed by the bone cells, number 3, and then the periodontal ligament cells, number 4. There is several types of healing which may occur, either by wrong junctional epithelium, as we see in figure C, or by accumulation of connective tissue in the root surface, which may cause root resorption, or by connective tissue regeneration or new attachment, as we see in D. Regarding the biologic principle relating to new attachment, studies on animal models as well as on humans demonstrated that it was possible to promote regeneration of new connective tissue attachment by selectively favoring repopulation of the detached root surface by periodontal ligament cells. This biologic principle is known as guided tissue regeneration, or GTAM. Following the traditional open flap debridement procedures, the fast-moving epithelial tissue often migrate into the defect space, forming a long junctional epithelium. When this occurs, restoration of cementum, periodontal ligament, and bone previously lost due to periodontal infection is often minimal and unpredictable. This figure simply represents the theory of GTR. The rabbit here represents the fast-moving epithelium and connective tissue cells, and the turtle here represents the useful cells of the periodontal ligament and bone. In order to allow the turtle or the useful cells to reach first to the defect space, we have to prevent the fast-moving epithelial cells and connective tissue of the gingiva from reaching first by placing a barrier between them. Therefore, the theory proposes that placing a barrier between the overlying gingival tissues and the defect space prevents the faster moving epithelium and gingival connective tissue from migrating into the wound space, allowing time for progenitor cells from cementum, periodontal ligament, and alveolar bone to repopulate the area. This is a diagrammatic presentation of a periodontal pocket. In A, we have the initial situation of the pocket after periodontitis. In B, the situation immediately after conservative or surgical treatment, such as scaling and root planing. Regeneration of the tissues, as represented by the arrows from 1 to 4, proceeds at various speeds. In C, healing occurs by means of lung junctional epithelium, minimal connective tissue regeneration, severe shrinkage of the gingiva. In G, the initial situation is present, but here we place a barrier membrane as we see in figure T. After flap procedure and membrane placement, the membrane separates the oral epithelium number 1 and gingival connective tissue number 2 from tooth and bone number 3 and periodontal ligament number 4. In R, a new periodontal ligament near new bone, new cementum with dentogingival fibers, blue arrows, and minimal gingival shrinkage occur. We can compare clearly the difference between the results in C and R. Guided tissue regeneration is applied to procedures aiming at regeneration of the periodontal structures and is known as guided periodontal tissue regeneration, GPTR, or to the regeneration of the alveolar bone, which is known as guided bone regeneration, or GBR. This concept is developed by Cannon and Kafasi in 1995. Patient selection for GTR. Candidate patient for GTR, or guided tissue regeneration, should be free of medical problems that contraindicate the periodontal surgical treatment. Patients should perform their willingness and ability to perform adequate oral hygiene. Number 3, they should be non-smoker. And the decision to treat patients requiring pre-medication should be made by the clinicians and patient physician, because there is risk of subacute bacterial endocarditis, and in cases of uncontrolled diabetes, in the cases of anticoagulant therapies. Defect selection for guided periodontal tissue regeneration. To select the defect to be treated with guided periodontal tissue regeneration, we should have at least 4 to 5 mm of attachment loss at the defect site. You should have a sufficient flap dimensions, including adequate zone of gingival tissues. This is to allow the closure over the membrane. The presence of keratinized gingiva is also helpful. We must have some remaining periodontium to allow the regenerative capacity. A defect morphology that allows for space creation and maintenance should be selected to allow for clot stabilization and guided tissue regeneration. The favorable types of defects that can be treated by guided periodontal tissue regeneration are class 2 furcation defects, 2 or 3 walled vertical defects, interproximal defects, distal defects, and localized gingival recession with intact interproximal papilla and good interproximal bone height. While the less favorable types of defects include class 3 furcation defects, horizontal defects, one-walled intrabony defects, shallow intrabony defects, and multiple tooth recession defects. For guided bone regeneration, we select the localized bony defects such as a residual osseous defect or extraction socket defects, and the defects which are associated with dental implant placement or repair, such as Dehisence defects, residual intraosseous defects, fenestration defects, and fresh extraction socket. This is a diagram representing the residual osseous defects and an extraction socket defect. A dehiscence defect associated with dental implants in the top, and a residual intraosseous defect associated with dental implant in the bottom. Fenestration defect and the fresh extraction socket associated with dental implant. Before starting the treatment with the process of guided tissue regeneration, the following steps should be. Number 1, a standard periodontal treatment should be performed by means of oral hygiene instructions, pre-surgical scaling and root planing, and pre-surgical medications according to the patient condition. Number 2, standard dental assessment, such as occlusal adjustment if needed, caries control, or endodontic treatment. Then we have to evaluate the patient factors, such as the tissue response to treatment, the oral hygiene, and the patient compliance. For guided bone regeneration before treatment, we must establish an appropriate oral hygiene program. If dental implant placement is involved, we have to follow the pre-surgical instructions for the device. And if treatment of failing implant is involved, we have to resolve any non-surgical conditions contributing to failure, such as occlusal adjustment. The site should be thoroughly cleaned and active or recent infection should be treated. We must notice that membranes should never be put or placed where active infection exists. If the patient wears dentures, we have to make sure they do not press directly on the material, and the reason is to allow space for clot stabilization and guided tissue regeneration. Regarding the materials used for guided tissue regeneration, we have either a non-resorbable barriers or a bioabsorbable barriers. For the non-resorbable barriers, the Gortex periodontal material has been the most widely used material for guided tissue regeneration procedures. The popularity of this material is based on extensive laboratory and clinical trials. It is considered the gold standard by which other membranes are compared. The material is made from expanded polytetrafluoroethylene, which is developed and patented by Gore and Associates, Flagstaff, Arizona. The manufacturing process can be adapted to produce any number of different configurations. The Gortex material is presented in two forms, either non-reinforced membranes or titanium reinforced membrane. And both the non-reinforced and the titanium reinforced membranes are present in two configurations, the transgingival configurations and the submerged configurations, or the Gortex augmentation material. The transgingival design is used to treat defects associated with the structures that extend through the gingiva, for example, a tooth. That is to say, for guided periodontal tissue regeneration, as we see in the first picture. The submerged design is used for situations where there is no communications with the oral cavity, that is to say, for guided bone regeneration. The material is designed to be submerged passive barrier, excluding gingival connective tissue, which may interfere with healing and allowing only bone access to the defect space guided bone regeneration, with or without implants, as we see in the second and third pictures. The Gortex material is made of an expanded polytetrafluoroethylene, which resembles the polytetrafluoroethylene. They are chemically identical, differing only in physical structures and strength. Solid polytetrafluoroethylene is non-porous and does not allow cellular ingrowth or attachment. In contrast, The microstructure of expanded polytetrafluoroethylene can be adjusted to permit cellular infiltration and collagen penetration. It consists of solid nodes interconnected by fine, highly oriented fibers, forming a unique porous structures as we see. The material is neither woven nor knitted, consequently, expanded polytetrafluoroethylene does not fray when it is trimmed and it is not abrasive. The transgingival configuration consists of an open microstructures or collar and an occlusive apron. The collar allows a space for clot formation and early collagen penetration. The clot and immature collagen fibers may stop epithelial proliferation by a process known as contact inhibition. And because the apron is occlusive, the gingival epithelium and connective tissue cannot come into contact with the root surface. Therefore, new attachment can only come from the periodontal ligament and endosteum as we need. For the submerged configurations, the material is stiff enough to create a space in which bone can form, but supple enough to drap smoothly over the margins of the defects to enhance flap management. The material has two distinct portions to address the specific biologic requirements associated with this application. The inner portion, which is stiff enough to facilitate space making and occlusive to protect the wound by minimizing cellular penetration, and the outer portion, which drapes smoothly over the margins of the defect to enhance flap management. It also allows greater tissue integration, which may add stability to the underlying blood clot during healing. This integration also minimizes the potential for connective tissue leakage between the membrane and bone. In addition, tissue integration with the outer rim of the material should retard the migration of epithelium if exposure occurs. The internodal distance in the collar of the transgingival configurations is 25 micrometer, while the apron has an internodal distance of 8 micrometers. The periodontal material is available in different forms and shapes to accommodate defect morphology and locations. For example, narrow anterior, single tooth narrow, single tooth wide, or posteriors, and so on. The material is provided in sterile envelopes and supplied with Gortex sutures. The non-reinforced Gortex augmentation materials is provided in two standard sizes, either oval 4 or oval 6. Titanium reinforced expanded polytetrafluoroethylene membranes with microstructural characteristics similar to the non-reinforced expanded polytetrafluoroethylene membranes were designed and presented by Gortex in order to increase the tent effect, which should be an advantage for defects that are not naturally space-making. They are intended to be used where the anatomy of the defect cause a non-reinforced material to collapse into the defect space, or where more space for regeneration is desired, as in the situations of gingival recession, some interproximal defects, and furcations. The titanium reinforced membranes are also present in transgingival configurations and submerged configurations. And also in different configurations and sizes to adapt the different sizes and shapes of the. After the appropriate configuration is chosen, it should be trimmed for adaptation of the defect. The material should overlap the bony margins of the defect by at least 3 millimeters. Over-trimming of the material may provide access for unwanted tissues into the defects. When trimming the transgingival configurations, do not completely remove the open microstructure portion, which is designed to inhibit rapid epithelial migrations. The material should be placed so that it will not move during healing. Movement in horizontal or vertical directions could compromise the regenerative results. Transgingival configurations can be stabilized with sling sutures, as we see, while the submerged configurations can be stabilized by a variety of methods such as sutures, cover screws, mini screws, and so on. We have to avoid creating sharp corners when trimming the material. Sharp corners have been seen in association with perforated flaps. When trimming the submerged configurations, do not remove all the outer portion, as it facilitates adaptation, integration, and stabilization of the material. Also avoid creating sharp corners on the material after trimming. Also, for the titanium reinforced membranes, when trimming the transgingival titanium reinforced membrane, do not completely remove the open microstructure portion, which is designed to inhibit rapid epithelial migration. When trimming the submerged titanium reinforced configuration, do not remove the entire outer portion. To minimize the potential for irritation or perforation of the flap, avoid cutting into the titanium reinforcement. To keep the layers from separating, do not trim within 1 to 2 millimeters of the titanium. Fine tweezers can be used to shape the titanium reinforced configurations for space making. Bend the titanium reinforcement to achieve the desired adaptation for the defect morphology. Avoid making folds, wrinkles, or sharp corners. Assure that the material is well adapted to the contour of the ridge. Gortex augmentation material placement and stabilizations. The factors most critical in the placement of Gortex augmentation material includes covering the defect, preserving a space under the material. We should preserve a space under the material, adapting the material to the bone or bone graft, and stabilizing the material, as we said. Also, we have to minimize salivary and other contamination of the material. More recently, a high-density polytetrafluoroethylene membrane was developed, GPTFE. For example, we have the Cytoplast, Regenerative, or TXT200. Those membranes are made of high-density polytetrafluoroethylene with a submicron of 0.2 micrometer pore size. The advantages of these membranes is because of high density and small pore size, bacterial infiltration into the bone augmentation site is eliminated. Furthermore, primary soft tissue closure is not required, as for example in case of implant placement in fresh extraction sockets or in guided bone regeneration. Interestingly, one of the materials, for example the Cytoplast, does not have porous structure and its attachment to tissues is weak. Thus, it can be removed easily by pulling on the membrane without lifting a mucosal flap. In addition, even if exposed, the risk of infection is less than that of expanded polytetrafluoroethylene membranes. The disadvantages of using a non-resorbable barrier membranes in general are: number one, the need for second surgical procedures to remove the membrane, which causes stress to the patient and additional time to the dentist. Number 2, the re-entry operation may cause trauma to the immature newly formed tissues, which may jeopardize the final results. Number 3, they increase the risk of gingival recession and thus facilitate bacterial colonization of the membrane.